rising numbers even last week. It has now been steadily, continuously the highest daily infection, the highest active cases, and the highest also in hospitalization. But overall in the country, active cases have reduced by 7%. Hospital admissions have reduced by 4.4%. And therefore, there is a little bit of relief on the pressure on our hospitals. But we appreciate the fact that this is just a little relief. Our hospital facilities are still under tremendous pressure, especially in the Gauteng, although the numbers have been reducing also with admissions, but rising in the Western Cape. So the pressure is there in the Western Cape, although overall in the country, there is a reduction of admissions. New cases overall over the last 7 days have reduced, again by just under 1%, 6.89%. The deaths from COVID, even though usually they are a little bit slower to reduce, because of the steady decline, also the number of deaths have been reducing, but still unacceptably high. The numbers are still unacceptably high. And of course, one death is just one too many, because as we know, this is not just a statistic, but it is somebody's sister, somebody's brother, somebody's father, and somebody's mother. And just to illustrate this, before I went to bed late last night, I got a message, very, distressing message that one of my very own old comrade and colleague, a leader of the student uprising in 1976 in Soweto, a leader of the then Soweto Students Representative Council, who was charged with sedition by the apartheid government and served not less than 6 years in Robben Island after spending a lot of time in jail in the John Foster Square in Johannesburg. Comrade Chaba then Munsisi, who also served as a member of parliament, National Assembly, and also Council of Provinces, passed away last night from COVID-19 complications. So this is again just a reminder that this is not just a statistic, but it's people at all times who are known to somebody. And in this case, we want to pass our condolences to the family of Comrade Chaba Munsisi, his children, and the rest of the family. The national positivity rate has also been going down from the high of 35% positive rate in the middle of July to the average over the last 7 days of between 19 and 20%. But to show that this is not yet stable, yesterday the average, the national positivity rate was 23%. But I must emphasize that even 19%, even though is a decline from the high of about 35, is still very high in terms of the WHO recommendation, which is 5% of a national positivity rate. So we're still far from where we can say we can have comfort that the third wave is really on its way out. Our situation therefore remains precarious, and therefore there is no time, as I've said earlier, to lower our guards, no time to release the restrictions, and therefore as a Department of Health, we will in no way be recommending to the National Coronavirus Council and to Cabinet a relaxation of the restrictions at this stage. We will be recommending remaining at level 3. Just to illustrate, as I said, positivity rate of 23% yesterday, and the overall national infection, daily infections yesterday of just over 14,000 from the low of just under 7,000. So it's fluctuating depending on the time of the week and the number of tests which are being done. So we must continue also our tried and tested protocols, which we all know. Our hospitals in all 9 provinces, especially we can speak more authoritatively about the public sector, and I'm sure Dr. Dombo, when she talks about Limpopo, although she'll be talking about vaccinations, can attest to this, that our hospitals still have enough capacity to handle those who need care. in our ordinary wards and also in our high care and in our ICUs. And on this note, I want to again thank our gallant health workers who continue to look after those who fall ill to this terrible enemy. We appreciate also the fact that they are being protected after being vaccinated during the Sisonke J&J vaccination. Very few of our health workers in this third wave have fallen sick, and this again attests to the efficacy of the vaccines which we are using. As we have said before, we are happy that currently, over and above the tried and tested non-pharmaceutical interventions, we also have in our arsenal the vaccination program, which prevents infection, but also especially severe illness, hospitalization, including ICU, admission in ICU and death. Now, as of yesterday, as we have been ramping up the vaccination program, we reached a landmark that is yesterday on the 12th of August at 18 hours. We reached a new landmark of just over 9 million vaccines doses administered. To be exact, 9.185 million. Dr. Nicholas Crisp will speak more about this. The number of people who have been vaccinated, it's just over 7 million, 7.25 million. The difference, just to explain to the listeners and viewers, is that the difference between the doses administered and the number of people is because, as we know, with the Pfizer vaccine, it's a double dose. Out of the 9.1 million vaccines administered, 1.9 million were second dose Pfizer vaccines. So, the fully vaccinated people in our country currently, that is either with the one dose J&J or with 2 doses of Pfizer. We now stand just a little under 4 million of fully vaccinated people, 3.958 million. So I'm quite confident that by close of business today, we will have crossed the 4 million of fully vaccinated people. I must, however, stress that there is ample evidence that even a one dose of the double dose vaccines, in this case, in our case, Pfizer vaccine, gives protection of up to 80% against severe disease, hospitalization, ICU, and death. So even as we want to make sure that everybody is fully vaccinated, I want to say to everybody, please come forward, because even the single dose is a good protection against severe illness and including ending up in the ICU and possible death. In terms of vaccine dose administered, just to give you a sense without going into all provinces, and again, Limpopo will give us their progress. At the national level, in terms of absolute numbers, Gauteng province, as the most populated province, is leading in doses administered, just over 1.8 million of that 9.1 million. 1.8 million of that is administered in Gauteng. Now, in terms of vaccination of the percentage of the population, the highest percentage, because it's one thing to have absolute numbers, but the question is how much of the population of that particular province is actually vaccinated. Now, in terms of as a percentage of population, the Eastern Cape province is leading with just over 23.3% of its population having received a vaccine. And second to Eastern Cape being a Limpopo province, which will present to us later on at just over 20.8% of the population. So it's very gratifying to see that the rural provinces are leading in the vaccination program. So we really want to thank the provinces which are really pushing the vaccination. Everybody else is pushing, but we just want to indicate that at the current moment, these are the provinces leading. Our female compatriots are leading in coming forward to be vaccinated. 60% of the women as against 40% of the men. So we again call upon us, our male counterparts, to come forward and register and be vaccinated. We also continue to vaccinate at workplaces, at farms, at mines, at factories. Just last week, I was with the MEC for LIMPOPO at farms in Zanin area, where I was very encouraged to see almost 90% to 100% of farm workers also coming forward in the 2 farms which we visited, coming forward to be vaccinated. And we also want to thank the management of all these workplaces, including the farms, the mines, and factories, who are encouraging their workers to come and register and be vaccinated. And in many cases, the management themselves leading by example by being the first ones to come forward. So we urge all people who are 35 years and older to come forward to register so that they can be serviced quicker when they arrive at the vaccinated site. Otherwise, they can just walk in on the vaccination site so that they can be inoculated. We have finalized agreement with various private providers so that they can also take people who are not on medical aids. Your big chain pharmacists like your Discount Clicks, but also, as we presented last time, the independent pharmacists also come on board. But we know that there are other providers, including some of the medical schemes, which are also providing services. We especially want to urge all people over the age of 50 and over the age of 60 to come forward before the 1st of September, when we will start opening for all people above 18. We have asked all vaccination sites, to prioritize, especially over 60 population and over 50 as they arrive on the virtual queue, but also on the physical queue when they come to the vaccination sites. We wish to assure South Africans again that the vaccines we are using are safe and effective. We have a system to monitor side effects and investigate where there is serious illness or death soon after vaccination. So far, we know that the deaths, many of those which have been investigated, which happened very near to after vaccination, have been found to be either because of prior COVID-19 infection, which happened before the vaccination and had not been detected, or other pre-existing illnesses. But more will be said about this by Professor Henry Meyer, who is also one of the panelists here. We have the experiences here in South Africa that, and also all over the world, that the vaccines really protect life. As I've said, the healthcare workers who had the Sisonke vaccination from early in February and March, and I can attest that I'm one of those who received the Sisonke. Dr. Mokheti, who also had a very mild infection. But also remember that also our President Ramaphosa, also had the J&J Sisonke, and also my predecessor, the former Minister of Health, Dr. Mkhize, also, and all the MECs also had the J&J Sisonke, and they're all doing well. And I think we can also just talk to our health workers in the various hospitals. They will tell you that indeed the Sisonke J&J has really protected them. More than 400,000 of them, and also more than 500,000 teachers have also been protected. And we're also rolling out to other people, including the police. And all over the world, there is evidence that only 1% of people who are admitted to hospitals with COVID-19 are actually those who are vaccinated, whereas compared to 99% of those admissions being those who are not vaccinated. Now, as we can see in various parts of the world, in the Americas, in Europe, the more people get vaccinated, the more the governments are able to open up more activities, more economic activities, more jobs can be saved, more social activity can take place, gatherings, religious gatherings can take place once we have got the full vaccination or more of the population vaccinated. Sports activities we have seen in some, especially in Europe, where even when they had a football and tennis and so on, they could allow crowds because more people have been vaccinated. Also in terms of traveling, especially international travel. So we urge all South Africans who are 35 years and older to please come forward and register using their mobile phones. As you know, there are various ways you can register also on WhatsApp. You not only relying on the internet, you can also use the USSD using the star 134 star 832 hashtag to register on the USSD. So we're also asking all leaders of society, our traditional leaders, our religious leaders, business, sports and culture icons to please come forward to help us in order to motivate all South Africans, make sure that as many South Africans would want to make sure that by December, the target of our interministerial committee led by Deputy President Mabuza is that by December, we must have at least 70% of the adults, if not 90, actually vaccinated. So I want to take this opportunity again to call on all South Africans to come forward. Thank you very much, moderator of this program, Mr. Foster Mohale. Thank you.
Thank you, Honorable Minister, for providing a picture of where we are in terms of vaccination program. Indeed, it's too early to lower our guard because the risk is still there, and we encourage all those who are eligible to register and vaccinate to go in numbers. Without wasting any time, Limpopo is one of the leading provinces as far as vaccination registration is concerned. So today we've invited the province to share with us the secret of success, the best practices, so that no province is left behind. So I'm going to call upon the Deputy Director General for Healthcare Services, Dr. Dombo, who's going to take us through the presentation from Limpopo Province. Over to you, Doc.
Very much, Mr. Mohale, and good morning to the Honorable Minister and the Honorable Deputy Minister and the rest of the colleagues. I will be sharing the best practices in Limpopo and in terms of what we have done so far in order to ensure that we reach our people. I will be going through the planning and coordination, as well as the phase 1 and up to phase 3 implementation, how we have done social mobilization and demand creation. And then I will also be looking into how far we are as a province and going forward our expansion plan, and also sharing challenges and success factors. In terms of our rules in Limpopo, we look at doing things that are specific to Limpopo. We are aware that we do not have unlimited resources. We're also therefore putting a framework that simply says, how can one person assist and what can that person do? Let's keep things simple, and let's understand our context to ensure that at all times we're speaking to the material conditions of the province. The situation is rapidly evolving, and so our response revolves accordingly. In terms of the service delivery platform, we started with understanding our situation, that we have 581 fixed existing facilities, which can be a delivery platform, as well as 2,720 existing mobile clinics, which visiting points. And so we know more than 3,000 contact points within the province, and that becomes our starting point when we came up with our rollout program. We also looked at, from a minimal perspective, without using any outside assistance, and also without taking staff from the hospitals, we could harness 169 vaccinators, and with minimum numbers per day, we believed we could do more than 8,000. And that became our starting point and added from there. So we then have scenario planning, which then tells us whether to scale down or to scale up to scenario 4, looking at how many vaccinators and the parameters around that. We look at the population in terms of our targets, how many people we want to reach over a specific period of time, the number of vaccinators at hand, how much time we have, including the expiry date of the vaccine in our stock, and also and that then determine how many people we can do and over what period. Now, this was the initial plan when vaccination was to be introduced in the country using the AstraZeneca, where we were going to use the hub and spoke from our hospitals and supporting the outreach facilities. However, that was not what transpired. We were not able to use AstraZeneca, and we moved on into the Sisonke process, and that had limited doses as well as limited sites. And as a province, we were not happy with that arrangement because, like I indicated, the time it will take to vaccinate the healthcare worker population was going to be much longer than what we had planned. And also in terms of challenges that we met during that time, in terms of registering employees and issuing vouchers. So we had an engagement with the National Health Council and the Medical Research Council, and we were allowed to expand and had a modified hub and spoke approach such that a single hospital per district would be the hub, and the district hospitals would be the spokes, and will spend maximum 2 days. And to ensure that we are efficient and benefit, we had an advanced team initiated, and they would then go and prepare the site and ensure that registration happened. And that approach was taken forward. So from that process, we learned that the hub and spoke practice can work. However, and it's also important to move fast to adapt. And we were able to vaccinate more than 33,000 healthcare workers by the 15th of May. However, it took more than 12 weeks. And it's important that in doing whatever work around this aspect, that you fight for what you know will work for you. So when we look at this process versus the DBE process, where it took us 32 days to vaccinate a similar amount of persons. And how we did that was we went back into our planning framework and we looked at the parameters, and we took a decision that we would vaccinate on what we call sector days, which are Fridays and in some cases Saturdays. And we were able to then plan around that, augment our vaccinators, increase the targets, and ensure that each site out of the 37 have a minimum number of stations, and that's how we're able to reach our target. When we went, therefore, into phase 2 and 3, we expanded our hub and spoke, and we now increased the outreach aspect. And as the qualifying age criteria is expanded, our model and delivery platform also expanded. And where in the beginning we were focused in a hospital setting because that's where the elderly were, and they are used to coming to our fixed sites for chronic meds and things like that. So we started at that level, and then we moved out also as we were getting confident with the management of the vaccines, the cold chain management, etc. We were then able to move out. So at this point in time, there's a high focus in terms of the outreach, and there are 6 arms that we have employed so that we can make sure we are covering everybody. We are cognizant that at this stage, most of the people that we are looking into are people who are economically active, they are in their workplaces. So we are not always going to have those people arriving into our facilities. Hence, our plan is to go to them. And so our approach is to ensure that there are 5 areas that we look into. We have our political leadership, who are our sponsors, our main spokespersons. We have a clear social mobilization where we use leaders local traditional leaders, church leaders, influencers. We also at this point are focusing on the pink slot, which is taking the vaccines to the people as much as possible and ensuring that our fixed sites, we are broadening that particular platform. So when we started with registration, looking into the introduction of an electronic registration system, understanding our context, that there are multiple ways of ensuring that the elderly could be registered. So we went with 3 areas where there was self-registration, starting with the first citizen of the province. And also then we encouraged family-assisted registration. And also we leveraged on our existing community health workers with cell phones, and they were able to then do assisted registration at that perspective. And using the rule of 1, we said if one community health worker out of the 9,000 that we have can register just 1 person per day, that is 9,000 people registered per day. And from there on, you can do, you can multiply. So if you look at registrations on the 4th of May, we were able to move by 42,000 by the 7th of May, which was in 3 days. So, and that is the model that we always use with the minimal resources that we have. So if you look at the influencers, we are grateful to the ZCC Church, which came forward. Both church leaders were able to show South Africa that today, together we can conquer COVID, and they have also been assisting the province and the country in ensuring that there is minimum church attendance, and also coming forward to show the country and their congregants that vaccination is safe. And we have also gone with traditional leaders, chiefs, traditional health practitioners. So these are all the aspects that we've used in this space. We also are clear in communicating our schedules and our sites. We even have local radio stations, 27 community radio stations that assist us. So the bottom picture there is just showing you one of our CEOs at the Mokopane community radio station broadcasting the schedule. This is our farming and work-based setting where we've gone to the mines. We've also gone to the farms across the province. We also reach out to sports and recreation groups over weekends, and we've had quite a good success in that aspect. On the community outreach for those elderly patients, one of our nurses on the extreme right going up the hill just to vaccinate the old lady at home, those with difficulty mobilizing. So we do go from house to house so that we are able to reach that level of community. The other community outreach that we do, we go to tribal offices, community halls. We have a drive-through vaccination station in Sinwabarana. So those are some of the areas where we're trying to be innovative to ensure that we are able to reach everybody. We've also gone into your high transit zones, such as the malls, and they've been quite assisting in giving us space and accommodating us during our vaccine drives. To that end, in terms of registration, we've reached 85% for the 60 years and above, 47% for the 50 to 59, and at the moment we're at 23% for the 35 to 49 age group. In terms of the registry, the vaccines administered, as of yesterday, 5 o'clock, we had reached more than 1 million in Limpopo. And so we're quite proud to have crossed the 1 million mark in terms of absolute numbers. And over the 24 period, we had vaccinated just over 20,000 people in the last 24 hours. In terms of the vaccine coverage against registered population, we also monitor that per age group so that we are able to see the cascade and the gap and what we still need to do and where we need to ramp up. And also the same in terms of vaccine against the actual population, so that we are able to know who we are still missing and how to augment the existing platforms and strategies within the province. So if you look at some of these graphs, for example, where we track the gap between the actual population, which is the first bar, followed by the second bar, which is the population vaccinated. So we are interested in the step between the population and the vaccinated for that population group. So we do this by district, because the districts are not always the same. And so your approach in terms of the 6 arms of the outreach approach that are indicated are in various stages of implementation, depending on the context, and the schedules are determined by the districts based on their circumstances. So going forward, we want to increase our fixed outreach, particularly as we're expanding to the younger age group towards the universities and the TVETs. We've started with our 2 universities, University of Venda and Limpopo. And we also want to ensure that our 481 primary healthcare facilities are primary sites. And to this end, so far, we've received 388 licenses. We want all our mobile clinics with their over 2,000 fixed visiting points to become fixed outreach, so that every day we know that by each month we would have reached all of those 2,000 points, and therefore that increases our number and continues to implement the rule of 1 and what can be done using that. Then finally, we want to start using the finding the missing in terms of the steps that are indicated. So in terms of the challenges, there are sometimes challenges with the supply of vaccine versus the demand, and also looking at our capacity, issues of internet connectivity, tools available so that all the teams are capacitated, also the ability to capture vaccination using a cell phone that still needs to be made available, the contract periods versus the recruitment, so that also some persons prefer permanent employment versus contract employment, issues of vaccine hesitancy, and also looking into our setting preference for walk-in service over appointment service. So looking at success factors, teamwork, dedication, a clear communication strategies, having effective and coordinated management. We are very clear in terms of our enrollment. It's very strategic. We have lead teams that go into various sectors and to ensure that prior to us arriving, people are already registered. We are very strong on responding quickly, and we push adaptation and innovation. And we've had assistance with donation from various stakeholders. But one of the things we continue to work on is that let's do this thing using bite-sized targets. What can one person do? What can we achieve at one place? Add all of them together, you get big results. Also assisting us is that we have a very willing and energetic champion who is the face of the campaign, and that is our MEC. So whenever we ask her to go to any place, she's available and in our presence. So I want to thank you, Chairperson. In a nutshell, that's Limpopo.
Thank you, Dr. Dombo, for sharing with us and everybody around the country your best practices. My kids will normally tell me that sharing is caring, and we believe that other provinces will learn and adopt some of the strategies that we've used in order to succeed as the province. Without wasting any time, we've been inundated with the public and media queries around the issue of vaccine side effects and adverse events following immunization. So today, we've invited Professor Henley Meyer from Sefago University, who is also the chair of a National Immunization Safety Expert Committee, to unpack the issue of adverse events following immunization. Without wasting any time, I'm going to hand over to Prof. Prof, over to you.
Thank you, Mr. Moali. I cannot share my screen. Now I can do that. Okay, good. Okay, good. Thank you very much. And good morning, Honorable Minister of Health, Deputy Minister, all colleagues, members from the media, as well as the public out there, listening to these presentations today. So it's really a great opportunity for me to share about the reporting of adverse events following immunization, and then specifically focusing on the vaccine safety. So I want to start off by saying that, all vaccines are tested during the 3 stages or phases of clinical trials before they are being approved. So it is very important for the public to know that for the vaccines that we are using here in South Africa, there were more than 43,000 volunteers in the phase 3 trials. So this means by the time they were authorized, we already knew the short-term side effects from these safety and efficacy studies. Now, people can then also rest assured that only if there's sufficient scientific evidence of vaccine safety and efficacy available will SAHPRA, our regulatory authority, these vaccines to be used. So now we are using them in the general population. They're not in clinical trials any longer, and large numbers of people are being vaccinated from different age groups. There are also now different subpopulations that's usually excluded in the clinical trials, for example, those with underlying medical conditions. So it's very important to monitor the safety of the vaccines as we are using them now in the real world. Now, uncommon, rare, and very rare vaccine reactions, they appear in approximately 1 in a million doses. So no clinical trial, although they have been very large, can be powered enough to detect these very rare and very rare adverse events. So there may be rare events after the vaccines are now being registered and authorized, but you have to weigh up the risk of experiencing those rare events, which is absolutely extremely small compared to the huge risk of getting COVID-19 disease. Oopsie, sorry about that. So I want to just quickly focus on the definition of an adverse event following immunization. So any health problem that happens after vaccination is considered an adverse event following immunization, but it does not necessarily have a causal relationship with the use of the vaccine. So as you can see, it could be any symptom, sign, a laboratory finding, or a disease. So an adverse event can then be either a true adverse reaction, which is also known and referred to as a side effect that is then related to the vaccine, or it could be a coincidental event that happened following vaccination. So if you look at this slide, it's quite busy, I know, but vaccine adverse events are expected to occur with a certain frequency, as you can see on the left. And then vaccine reactions in terms of the intensity can be classified as either minor reactions and severe reactions. So very common or frequent adverse events are usually the minor ones that we are very familiar with now. And then the uncommon, rare, and very rare adverse event are usually more severe reactions, although not always. Now, there is obviously low public tolerance of vaccine adverse reactions. So vaccines will therefore only be registered when the frequency of severe reactions is very rare and when only minor reactions are being reported. I quickly just want to mention that adverse events of special interest is also something that we are looking at with COVID-19 vaccines. So an adverse event of special interest is a pre-specified medically significant event, and it could be serious or non-serious. It has a potential to be causally associated with the vaccine, and it therefore needs to be carefully monitored and confirmed, if necessary, by further studies. So there are certain conditions shortlisted as adverse events of special interest, and they are then also being investigated to look at whether there is any causal link with the vaccine. And for this purpose, we need to then look at the incidence of these in the vaccinated population and compare it with the background rates or the expected rates of these conditions in unvaccinated people. Now, the minor vaccine reactions, they are the ones that is commonly being experienced. They don't pose a potential risk. It's the way that the body is now reacting as part of your immune response. They start usually within a few hours and they clear within 2 to 3 days. And we've seen that they are more intense or noticeable in the younger population, those who had COVID-19 before and those after a second dose of the vaccine, if it's a 2-dose vaccine. But it's important to seek medical assistance if these reactions, they become more severe or they are long-lasting, or there are any new onsets of symptoms within the 30 days following vaccination. And then these ones must be reported. So all vaccine adverse events must be reported because, as I said, it's important for us to monitor the safety of the vaccines. They are new vaccines and we need to profile them properly. Now, serious or severe events could either be serious or non-serious. So the non-serious ones, they usually resolve within a few days. They can be disabling, but they don't result in long-term or persistent outcomes, and they are really life-threatening. The serious events are those that result in death, hospitalization, it's life-threatening. They have persistent outcomes, disability or incapacity. They could result in a birth defect, and it could also be medically important events or reactions. They are also considered serious events. And these ones, all of them need to be reported, and they must be investigated, preferably within 48 hours. So this includes then deaths under the serious events. Now, the question is, how do I report an adverse event following immunization? So it's very important that people should take note. As soon as they experience something of concern to them, they should seek help at a health facility. That could be a clinic, a private practitioner, or a hospital, or a community health center. And then the adverse event is reported at the health facility. They can also report it themselves using the MedSafety app. The MedSafety app is also being used by healthcare workers. So if you feel that you don't need to seek medical help and you can report it yourself, then you can do that. If you need assistance on the whole reporting process, you can phone the COVID-19 hotline. But please take note that when you do report, make sure you provide all the necessary information as it is being requested in the MedSafety app. So talking about the MedSafety app, it's a mobile application free for download on Android and iOS devices. It's electronic reporting that you can use for reporting your adverse events offline, in other words, do the report and submit it afterwards. So all the information about the MedSafety app is available on the SAPRA website. There's also a promotion video that everybody could share on their social media pages. Now, I just want to emphasize here, all of this is done, as I said in the beginning, to monitor the safety of the vaccines. So when adverse events are being reported, they are investigated. From there, causality assessment is done by the National Immunisation Safety Expert Committee, and then feedback is given to the facilities. And this is all done to make sure that the public can rest assured that the program is it's good, the vaccines are safe, and there's good and high integrity within the immunization services. So with regards to causality assessment, that is now done just to define it or describe it in more detail. It means that these cases are systematically being reviewed to determine whether there is a causal association with the event and the vaccine that's been received. So when we look at the causal association, cause and effect relationship between the causative factor, which is now the vaccine, and in the outcome, but there must be no other factors intervening in this whole process. So causally associated events are temporally associated, which means the event occurred after the vaccine has been administered. But events that are temporally associated may not necessarily be causally associated. So it's important to understand these concepts. And we do all of this to avoid people concluding automatically just because an event happened after vaccination, it therefore happened because of vaccination. And that is why these cases must be investigated and causality assessment must be done. So the case investigations, they are done by the National Department of Health. They have teams within the districts and the provinces. And as you can see, these teams consist of a group of medically trained healthcare personnel. Then the National Immunisation Safety Expert Committee. This is a non-statutory, it's a ministerial appointed advisory committee. It's completely independent from the Department of Health and SAPRA. They then look at these cases and they do the causality assessment and finally classify these cases. And I'll show you about the classifications now. Then eventually they also provide independent advice and recommendations to the National Department of Health. So for causality assessment, this is a very important slide. These are the prerequisites. So if the case has not been investigated properly or completely, causality assessment cannot be done. There must be a specific diagnosis to work from. So if you have a case which just says a death or a natural death, then there's no specific diagnosis and you cannot proceed with the case. And then all the evidence must be available. So if you look at the right-hand side of the screen, you'll see all the information that is required to make sure that there are no other factors involved in this whole process to be able to, in the end, say that this has been caused by the vaccine or not. So now for the classification, so if there is a causal relationship, these cases are then classified either as a vaccine product-related reaction. So that would be those side effects that you would find in the product information. It could be a quality defect-related reaction. So in other words, if there's something wrong with the quality of the product itself. Then there's also immunization error-related reaction. So if there has been a problem or a mistake in handling the vaccine or the prescribing or the administration, and as a result of that, there is a reaction, then it would be classified into this category. And then the last one is anxiety-related reactions. So this is seen amongst adults or adolescents where people are scared of the immunization process or they have fear of injections. Then there's inconsistent with causal association. So this is very common now with COVID-19, which means that the event happened after vaccination, but it wasn't caused by the vaccine or the vaccination process. And as I said, it is very common now with COVID-19 because people have multiple comorbidities. It could also happen with healthy individuals. It could be a new disease that's been diagnosed. It could be a spontaneous occurrence of an event without any known risk factors. There could be other exposures to medicines, to other treatments. There could be trauma involved. So for this purpose also, looking at the expected background rates is very important to determine whether this, happened coincidentally or whether it has been as a result of the vaccine. Then the last one is indeterminate cases. So here you would find, for example, your adverse events of special interest, where there is a temporal relationship, but there's insufficient evidence to say with certainty that this has been caused by the vaccine. Or there could be conflicting trends or inconsistency with causal association. Then the very last one, and it's a very unfortunate category, is the unclassifiable category. So this is then where you start off with a case, but you cannot proceed because the case end up to be ineligible for causality assessment, because the amount of information available is so limited that assessment cannot be done. For example, if you get a report, there's no vaccine mentioned, there's no vaccinee mentioned, there's no province mentioned. You just know somebody died and that's all. So nothing else has been reported. Then you cannot trace the case and you could do nothing with it. Then the other one is an unclassifiable case, so where you are able to proceed with the causality assessment, but in the end, you don't have sufficient information to classify this case. For example, if there's an autopsy report outstanding in the case of a death. Then lastly, I just want to emphasize the importance of reporting these adverse events and seeking treatment. So people should seek treatment when they experience symptoms of concern. And they should not assume that these symptoms are reactions to the vaccines. They could be coincidental to the vaccine. There could be something else wrong with them, something very serious. It could be, for example, if a person is coughing, it could be TB or community-acquired pneumonia. It could also be underlying COVID-19 infection because of the situation at the moment. So it's very important to immediately report all severe events and make sure that you seek treatment at a healthcare facility should it be necessary, or if you have any doubts, make sure that you seek treatment. I would like to just acknowledge everybody who's been involved in strengthening the vaccine safety surveillance program. A lot has been done in the past 6 months, and as you can see, a lot of organizations and people have been involved in this whole process. Thank you very much.
Thank you, Prof. Mayor, and for your comprehensive presentation as far as side effects and adverse events following immunization is concerned. We believe that through your presentation, we have allayed fears that the people, those who are still undecided, they can quickly go to vaccination sites to get this life-saving treatment. Without wasting any time, I'm going to allow Dr. Nicholas Crisp to give us the national picture as far as vaccination is concerned, vaccine supplies, vaccination sites is concerned. Over to you, Doc.
Thank you very much, Foster. Morning, Minister. Morning, Deputy Minister, DG and colleagues, and ladies and gentlemen. I'll go through quite quickly and just give an update, but I want to emphasize what the Minister said. Vaccines are effective and they are safe, and it's not for fun that we are trying to get coverage. So just very briefly, the current vaccines that are available in the country are many. If I show with a laser pointer here, up to this week, we have received the vaccines that are shown on the left-hand side of this table, both Johnson & Johnson vaccines and the Pfizer vaccines, and then we received a large donation from the American government in the past 2 weeks. And so we are in a very good, stable position as far as vaccine is concerned, both in terms of Johnson & Johnson and Pfizer. We are expecting more Johnson & Johnson deliveries during the month of August, and we are expecting to continue with our weekly consignment arriving of the Pfizer vaccine in the weeks ahead. And then we have a longer-term vision of the last quarter with another 28 million doses that are due to be delivered after the end of August. In terms of registrations, we are disappointed that registrations are decreasing. And one must remember that registrations are done both pre-vaccination and people who arrive for walk-ins are registered at site. So this figure is everybody who gets registered. And so the daily registrations yesterday was only 53,000, which is really a pretty poor show if you think how many people still need to be registered and vaccinated. The total registrations so far are 9.2 million. We do have a lot of vaccinations done where people are not registered in this way. They are done in bulk registrations, such as the 1 million people who have been vaccinated in the general essential services program. But there's a lot of room for improvement. We have seen 3 million people in the 35 to 49 category, but there are 12 million people in the country in this age group. So that's really not enough. And in the 50 to 59, 1.9 million registrations so far, but there are 4.5 million people in that category. So there's a lot of work to do still to get people registered. As far as our daily vaccinations are concerned, this graph shows you each of the provinces in a color. And this is the Sisonke period from February up to the 17th of May, when there were healthcare workers being vaccinated, as we've heard before. From the 17th of May, the national vaccination program built up until we started to run short of vaccine 2 weeks ago, or about a little bit more than 10 days ago. And we've lost impetus in the vaccination program, as you can see here in Gauteng, Western Cape, and all the other provinces. Every province has lost momentum. Although we are seeing a nice increase in the total number of vaccinations, and as the Honourable Minister said, we have crossed the 9 million mark, this slowing down and drop-off of vaccinations on a daily basis is something that we really need as a nation to pick up if we are going to protect ourselves and keep people out of hospital. There will be a fourth wave, we have no doubt. We don't know when, we don't know how severe, and we don't know which variant, but we need to protect ourselves by vaccinating. So we have had 9.185 vaccinations up to yesterday afternoon. Of that, just over 2 million are Johnson & Johnson vaccines. That's the initial Sisonke program. You will see the numbers increasing slowly as the paper records are found and captured into the system. We are now at 493,000 Sisonke vaccinations on J&J, but 1.5 million vaccines have been administered since the start of the national program. Now, those who have been watching the short expiry date vaccine will know that this number exceeds the number of short expiry date vaccines. So we've used all of that vaccine, and the new Johnson & Johnson vaccines are starting to find their way into the system now. Pfizer vaccines, the Honourable Minister has explained this already, that we have administered 7.164 million doses up to yesterday. Of those, 5.2 million were first doses, and you can see in the graph per province the numbers of vaccinations administered, and just under 2 million second dose Pfizer vaccines have been administered so far. In terms of individuals vaccinated, the Minister explained this very clearly, I thought, but I'll repeat it. We have vaccinated 7.25 million individuals. And of those individuals, those who have had either one dose of Johnson & Johnson or both doses of Pfizer is just under 4 million, and that's our fully vaccinated population. So we watch three figures: total vaccinations, individuals vaccinated, and individuals fully vaccinated. But you can see in the graph on the right-hand side that we were picking up tempo nicely, and it's dropped off in the last 2 weeks, with a moving daily average of the green line decreasing. But what has been encouraging is that the graph is lifting off the baseline over weekends, which means that some weekend sites are vaccinating and seeing people during the week. We are also monitoring daily vaccinations by province, by district, by sub-district, and by site. And it is possible then to watch the daily moving averages. In most weeks, we see a decrease especially on Fridays, but now with this decrease in the last couple of weeks, while vaccines were getting back into the system and the momentum of the program is lost, is something that we all need to watch carefully, and we'd like to see these graphs pick up substantially on a daily vaccination rate. And I think we can all learn from what we heard from Limpopo. If we keep it simple and we just go at the small numbers that add up across the country, that's the way to do it. We are watching the gender, the sex and age group distribution of the vaccinations administered, because we are trying to get the older people vaccinated, since they are the most vulnerable. They are the population the men are not being vaccinated in the numbers of the women in all age groups. So what you see here is the percentage of total vaccinations in each of the age groups. You may ask why we're seeing people under the age of 35 or under the age of 20 even. Those are mostly health students who have been working as vaccinators as part of the health system. There are some travelers that have been vaccinated to allow them to leave the country, who are to go and study abroad, and some of them work abroad under the age of the current 35 years. So we are seeing 60% of the people vaccinated at the moment are female and 40% male. And I want to appeal again to men. This is not good, because it means that men are going to end up very sick and in hospital, and we don't want that to happen just prior to Christmas. In terms, I'm almost through this. We are monitoring how of the individuals vaccinated. You heard the Honourable Minister say we have a target of vaccinating 70% of the adult population by the end of the year. Well, the adult population is this bar here, which is 40 million, 39.798, so call it 40 million people. The individuals vaccinated is now sitting on 7.2 million, the fully vaccinated just under 4 million. We need to get this bar to 70% of the green bar on the left-hand side by Christmas, and that means we need to have vaccinated 28 million people by the end of this year if we are to get to that level of protection. But we are interested in making sure that the older population is fully vaccinated within the bar of this intent. We can see the figures relating to these bars and the relative distributions across the provinces of the individuals out of the population who are vaccinated and who are fully vaccinated. And we can see we are sitting on 18.2% of the population of this 40 million have been vaccinated so far, of which, and 10% are fully vaccinated. So quite a long way to go to the target of 70% before the end of the year. So our conclusion at the moment is that we are sitting in a situation where we don't have a vaccine constraint, at least for the next 2 months. Our vaccination capacity across the public and private sectors with all our clinics, what you heard from Dr. Dombo, and all the private sectors that we heard from Jackie Myman last week, and all the other sites, that vaccination capacity is strong. Now we need vaccine demand, because it has decreased with the loss of impetus in the program. The 35 to 49-year-olds had a very good start, but have not sustained their interest, maybe thinking there's now enough vaccine, I can take my time. But we want to caution people, once the young group of 18 to 34-year-olds arrives, there are 17 million people in that category from the 1st of September, and they will come in numbers for vaccination, I am sure. And then the 35 to 49-year-olds are going to wait in longer queues once more. And a last appeal to men to not trail the women in vaccinations, and please to come forward so that we can vaccinate you. Thank you.
Thank you, Dr. Nicholas Cripps, for that assurance that in terms of vaccine supply, we don't have a problem. So we need more arms to come and take this vaccine. We also encourage, challenge all men of all ages, as it has been said, that they need to come to get this vaccine in numbers to protect their families and the communities. So without wasting any time, we're going to take questions and answers before we conclude with the Deputy Minister. I'm going to read the first batch of questions, and I'm going to request all the members of the panel, some of the questions that they see on the chart, they can just respond instead of waiting for me to respond. So we are going to be joined by our DG, Dr. Sandile Uteles, who will be assisting us with the questions, together with Dr. Anban Pillay. I've seen Dr. Popira Matua, the MEC of Health in LIMPOPO. She's here. She will also assist where there are questions that are related to the province. So without wasting any time, I'm going to start taking the first batch of questions. The first questions read as follows. People should be screened before vaccinating. Why is the daily testing coverage population less than the vaccine coverage? The second question says, when is the EVDS registration going to open for under 35, since we've got enough vaccine supply, meaning that we can be able to deal with the demand? The other question is, when are we going to add Sinovac vaccine into the mix of our vaccines? How far are we as the country or as the department and SAPRA with the application for Russian Sputnik vaccine? How many doses of J&J and Pfizer vaccines have been delivered in the month of August? I think Dr. Crisp has touched on this one, but if you feel you want to elaborate on this, feel free to do so, Dr. Crisp. When are we going to vaccinate children below the age of 18, particularly those who are in primary and secondary school? Let me take another question. The other question is, could the number of vaccine deaths be much higher than the department has recorded? If so, what could be the reason, and how does SA COVID-19 death compare to the rest of the world? I'm going to take this few questions and allow the panelists to respond. Then we'll take the second round. I'm not sure who's going to start. Minister, colleagues?
Foster, can you just repeat that first question? I don't know if other colleagues might have got it clear. Maybe just repeat the first one.
Yeah, the first one is saying people should be screened before being vaccinated. Are we screening them before we vaccinate them? Like you're taking the blood pressure and checking other health conditions before we vaccinate them, since we always encourage that those who have got the symptoms, those who have taken a flu shot, they don't have to take vaccine immediately. So they must first wait for a particular period. So are we doing that to ensure that those who are vaccinated, they are being screened first? And the part of this question say, why is the daily testing coverage of population less than that of vaccine coverage? I'm not sure if you got it, Minister.
Okay. No, that's fine. I think let's check maybe amongst the team members. There are some which are straight for Dr. Crisp. Yeah, so maybe Dr. Anban Pillay, I don't know if Dr. Leslie Bamford is also on the platform, maybe not, but yeah, DG could also come in. Let me allow the team members to come in and take some of the questions. Thank you, Foster.
Minister, thanks very much. Maybe I'll deal with the ones that are clearly in my patch. The first one is that the registration and vaccination of under 35s will start on the 1st of September. We've learned from the previous opening of age categories that once you start registration, you must vaccinate. So it's about 2 weeks to go, and then the under 35s will start vaccinating. The question about children under the age of 18, our vaccines are not registered for use in children, but there are studies that are being done both by the manufacturers and being evaluated by both the Vaccine Ministerial Advisory Committee and by SAPRA. And when the evidence is clear and we understand the implications, I'm sure the vaccine age registration will change. And at that point, we will vaccinate children below the age of 18. At the moment, the evidence that's being looked at is the category 12 to 18. As far as I think the first question was, why are we not testing before we vaccinate? There has been a long discussion in the Vaccine Ministerial Advisory Committee about this. It's about having a cost-effective test, and it's about doing small studies first to establish whether that is cost-effective, in fact, to do the test to exclude people who already have enough immunity. So it's not that we have not considered it or not looking at it. It's just that we need to have the economic and the scientific facts to make sure that that is the most effective way to do it. Let me leave other questions to others. Thanks.
I don't know whether somebody else, I thought you would also venture into the addition of other vaccines as to where the process in terms of the SAPRA. But let me just also add on the first one to say, while Dr. Crisp is correct that in terms of the balance of benefit in terms of subjecting everybody who comes for vaccination first to do a COVID test. That is not done anywhere in the world. It's not really cost effective. But what anybody who's been through vaccination will tell you, there is a thorough screening in terms of before you go to the actual vaccination, where your basic, medical history will be taken in terms of allergies, in terms of whether any other comorbidities, treatments you are taking, and so on. Just a basic medical screening, including whether you have any fever or cough and the kind of symptoms which would generally be associated with a fever, whether just in terms of a flu, or which could be a risk that you might already be having a COVID-19 infection. So that basic screening is done before, and I'm sure also other colleagues could attest to that. That's really very standard. So while we are not doing actual COVID test, but there is a basic screening which is done. But if I can ask Dr. Crisp also just to quickly respond to the issues about the addition of other vaccines. Thank you.
Okay, thank you very much, Minister. So just briefly on the Sputnik, it's not through the evaluation by SAPRI yet, so the vaccine is not registered. So we are not looking at it from the Department of Health's perspective yet. There are two vaccines that are registered, that is the Sinovac and the AstraZeneca. There are conditions under the registration of Sinovac vaccine that need to be met for the vaccine to be used. So we are looking at those conditions from an implementation perspective, which includes that further studies need to be done to answer questions for which there's insufficient evidence, and that SAPRA said there's not a good reason to say that the vaccine can't be used, but there's not enough evidence to say that we understand how it will behave, for instance, with the Delta variant and in populations with HIV. That work is being planned together with the Departments of Science and Innovation and the Medical Research Council, and will form part of an initial vaccination or introduction of an initial amount of vaccines from Sinovac when the time is right. So those are the answers to those two vaccines, Minister. Thanks.
Foster, there was a question, I think the last one, if you could also just repeat that one, something about deaths. I don't know whether it was about vaccine-related deaths. Foster, can you come back? Just repeat the last question so that we can know who would be best to deal with it.
Minister, let me look at these questions.
Yes, it was something about vaccine death. It was your last question.
The last question was, I think it's already answered, say, when will the vaccination of children under 18 be vaccinated? But there's another question that was related to
no, there was another one after that, which spoke about death.
Yes, the question was, there was a study of findings by MRC recorded. Why is that?
Okay. Let me just deal with that. I think Prof might have touched on that. I'm not too sure, but it's essentially the concept of excess deaths. We have discussed it in previous media discussions. Just very simply and quickly to say that what the Medical Research Council does, it looks at any given time the normal pattern of deaths in the country per year, per month, per week, the average in terms of natural deaths and also unnatural deaths. And it picks up if there is something out of the normal trend. And once there's something abnormal, that's what it's called the excess deaths. Now, in the situation for now, for instance, where there is a pandemic, there are deaths which we report, which are outside the normal pattern of death, which we then attribute to COVID-19 because there has been clinical signs, there has been laboratory confirmation that the person died from COVID, not just the clinical, but also laboratory confirmation that the death was due to COVID-19. But then there are people who will die without having been tested, may not be clear whether it was actually COVID. Now, the MRC then, while there will be the normal pattern, there will be the deaths which we report that these are due to COVID-19 because not only clinical, but also laboratory confirmed. But once there is even more deaths outside the normal annual pattern or monthly pattern, and which are not even explained on the basis of positive COVID-19 tests, but they show that it's more than the normal. Just to be as an example, let's say per week there is normally 100 deaths, and then we attribute then there is 150 instead of 100 as normal. And from the COVID test, we can only explain 30, and therefore it becomes 100, which is normal, 30, which is abnormal, which is explained by positive COVID test, but there is another 20 which is not explained. That's what the MRC will report as excess death. But we can't add that to COVID, even if it might be people who died from COVID but not tested, because you can only confirm that this is COVID death when there is actual laboratory confirmation. So that I know this question has arisen in other platforms, and one just needed to explain to that. Maybe we could take the last batch, Foster.
Thanks, DM and colleagues for responding to those questions. I've got one question. This one will be directed to the colleagues in Limpopo. Israel Nkuna is saying, is talking about the issue of a mobile bus. He said in Limpopo, they don't have full equipment, especially for vaccinating people. What are the plans for Limpopo in near future to have full capacity in terms of equipment? The other question is, let me go. The other question from Mia Malan from Begisisa says, is there a system in place for airlines and embassies to be able to use for vaccination SMSs to get vaccination to verify that they're authentic? So airlines are able to phone the numbers to contact the department to verify whether those SMSs to confirm that one has been vaccinated is true or not. The other question is, are there plans to utilize social media more comprehensively to promote vaccination? Can we elaborate this one? On this one, yes, I can respond to this one without any fear, that we do use all the different platforms to encourage people to register and vaccinate. The other question is, what is the turnaround time for applications for special vaccination? So people who use special application forms who like to get vaccinated before the age group, especially those who are traveling internationally, can be able to be assisted. The last question is, at what point is it safe to vaccinate after infection and recovery from COVID? What is the scientific explanation for warning the natural immunity after vaccination? What are the signs to avoid the quick vaccination immediately after being vaccinated? I'm going to take only these few questions so that we'll have enough time for closure, Minister and the members of the panel. Then the rest of the questions, colleagues will encourage colleagues to feel free to communicate with me so that I can be able to link them with all the members of the panel so that all the questions they get answered even after this media briefing. Over to you, the Minister and the panelists.
Can we ask maybe MEC Ramatuba? There's a question about increasing capacity for mobile. I think that's what the question was saying. MEC or Dr. Dombo? I don't know who's going to take it. Limpopo, is there a problem with connectivity?
Thank you, Honorable Minister. In terms of the question in relation to how we can get to the rural areas, hard to reach areas, So as I've indicated, that already that is part of our outreach strategy in terms of the arms that we have come up with. So it is something that has already started, and hence the expansion plans that over and above the fixed sites that we are planning to mobilize and deploy, we also are looking into improving and augmenting that extended outreach into the homes and or the villages, and why we are working with traditional leaders to use tribal offices or community halls as sites. So each week there is a schedule which is done because we have realized that using fixed sites at this point in time is no longer the primary objective in terms of using hospitals as primary sites. Most of the numbers that we are getting are currently being done at outreach sites. So when you look at our schedule, our weekly schedule, each district, each sub-district is expected to have outreach sites within the community, in all the villages, and so on and so forth, and why we even go to the farms in terms of work-based strategy. Going forward, we'll be increasing that. We are procuring vehicles. We have hired vehicles as well to assist us in that regard. We've also got in the pipeline stakeholders who are looking into assisting us with mobile vaccination units, which they will provide with a driver and some staff, and we will provide the vaccine. So we are working hand in hand with those stakeholders who are able to assist us in that regard. In terms of, in the beginning of COVID, during the household screening, Honorable Minister, in Limpopo, we had a program where we had a clear schedule of visiting villages. We used something similar to the load shedding, with color coding, and being very clear on which Tuesday, on which Wednesday, and so on will be at which village. And we are going to also then use such strategies to go forward and ensure that over and above the issue of proximity to a health facility, how then do we get to those villages or communities where there isn't a fixed site near them? And also why in our expansion plan, we are saying we have mobile clinics, primary health care clinics. So let those mobile primary health clinics with their existing schedule also now start vaccinating. Even if they are vaccinating small numbers, but at least through that schedule, we'll be able to reach those communities because we are going there anyway on the basis that they don't have a fixed site. So that is something that in terms of going forward, we're looking at. Obviously, it's all linked to the tools of trade, particularly as vaccination is captured using electronic ICT material. And to that effect, we do have orders out. We are expecting delivery in October, for example, of 1,000 laptops. We have received more than 400 at the moment. And we have also received SIM cards from the service providers, data service providers, to enable us to activate that platform. So depending on what we are receiving in terms of supplies, as well as our cold chain storage, then those teams will be deployed accordingly as those items are received. Thank you, Honorable Minister.
Thank you very much. Can we get the other, I'm sure, I don't know whether Dr. Anban Pillay, Dr. Crisp on the airlines to confirm the SMS. I think maybe it might be Dr. Crisp or DG, the special application for traveling. And I'm sure the Prof can deal with the one of when after a COVID-19 infection, you can be able to do a vaccination. Dr. Crisp?
Thanks, Minister. Just briefly, the special vaccination for travel is it'll only be in place until the 1st of September, because after that, anybody can register and vaccinate anyway. So for the next 2 weeks, we are processing applications that come for people under the age of 35 who wish to travel, and are issuing codes so that they can be vaccinated as quickly as we can get through them. As far as the verification of codes are concerned, we haven't had airlines querying so far, but if they want to query, they can contact the department through the helpline, and we will be able to verify that those codes are in fact codes that are valid for vaccination. Thank you.
I wasn't sure whether, Prof, would you take the one on when after having had the infection?
Yes, I can do that, Minister. So after you had a COVID-19 infection, you need to wait 30 days at least before you get vaccinated, or 35 days since your positive test. But I would say 30 days since you have recovered, then you can go and get your vaccine. There was also a question about the waning immunity. So it has been shown up to date now that the natural immunity doesn't last as long as the vaccine-induced immunity. But you know, there's still a lot of research going on about that, and it's not conclusive, all the mechanisms being involved, because they work in different ways. But yeah, at the moment, your vaccine will give you better, long-lasting immunity compared to just after you had an infection. You will have some immunity, but it's better to get your vaccine because it will be a booster and it won't harm you. Thanks.
Back to you, Foster.
Thank you, Minister, and the members of the panel, together with the colleagues in the province. Now we are heading towards the closure. I'm going to, as I prepare to call Deputy Minister Dr. Domo to come in, just to formally introduce him. Dr. Domo is one of the few longest serving MECs for health in South Africa. He served as the MEC for health in KZN between 2009 and 2019, which is 10 years. His long list of academic qualifications include Bachelor of Medicine from University of Natal, now called KZN. He acquired the BA degree from UNISA, which while he was incarcerated in Robben Island. Dr. Domo is an intellectual, freedom fighter, medical practitioner. He's a former chair of Portfolio Committee on Health and is the newly appointed Deputy Minister of Health in the Republic of South Africa. Over to you, Doc.
Program Director, for your warm welcoming remarks. And let me also quickly join my minister on the messages of condolences to those who have passed on over this period, including some of our healthcare workers. And he says there's a few numbers now of our healthcare workers. It's encouraging that this is actually getting to our ground. The warm welcome from the minister. The minister forgot to mention that he has mentored me for the past 40 years, both academically and politically, since we met in 1980. And I look forward, Minister Phaahla, for your mentorship to continue even at this time that we are now in this space together. Opening remarks of Minister Phaahla and subsequent presentations reminded us that at the beginning of this year, we had limited doses of vaccines, but in August now, as we speak, we have enough vaccines. The situation going forward, it actually tells us that we'll continue to have enough vaccines. At the beginning of this year, we had limited vaccination sites. In August now, this year, the program has expanded so much that the vaccines are taken to where people live, where people are working, including farm workers, miners, community halls, malls. So there is this that we are taking vaccines to the people. So the attitude of the Department of Health and our government is that no one should be left behind. If you are there for 60 years and above and you have not really vaccinated, we really encourage you to do so. 50 years and above, also the same, because in the 1st of September, it's a new batch of our South Africans who will be put in there. why do we encourage our citizens to vaccinate? From the minister and the scientists, we are informed that vaccinations reduce COVID-19 infections from being a threatening infection or illness to just a flu-like illness with few days of discomfort and inconvenience. Now, there's a significant reduction in the ICU beds, in the deaths. This is where we would like to take our South Africans. In most societies, South Africa being one of them, we now learn that citizens that have a health-seeking behavior are women. Malibongwe. They visit health facilities just to check if everything is still okay. Men do not do that. We are therefore pleading with men that please, in your busy schedules, do find time to visit vaccination sites. We have enough vaccines now. We need to get to the herd immunity soon. In closing, Minister, we cannot thank Limpopo province enough. The leadership there, Premier, MEC, traditional leadership, and everyone for what actually they've done. And there's nothing wrong, Honorable Minister, to take the good lessons from Limpopo and maybe as national, see how they can be adopted and be innovative for other provinces. But as you could hear the presentations, we are saying in Limpopo again, we have seen a significant visibility of the faith-based leadership, and we would like to see this also happening all over our country. Traditional leaders, and the minister is speaking about also getting into the sports fraternity so that we can really move our processes. So if we can really be able to motivate and accelerate these processes in those institutions, we will go a long way towards actually achieving what our president is calling on to really get a herd immunity by end of this year. Thank you very much, Mr. Foster, and to the minister and to all those who have been part of this. And I'm grateful for the welcome that you have given to me to this department.
Thanks, Deputy Minister, Honorable Dr. Jomo, for your kind words. Let me take this opportunity to thank Honorable Minister officially and the Deputy Minister, members of the panel, media houses for their continued support, including those who have joined through different channels, your TV, your radio, social media. Until we meet again, I thank you, and I encourage all men to continue to register and vaccinate to protect their families, as we know that the men are protectors. So let's show that indeed we are protectors by taking the vaccine to protect our families and our loved ones and our communities. I thank you.
Thank you very much.
Thank you very much.
Thanks. Goodbye.
Very much. Goodbye.
Bye.